So, good afternoon, and I'm happy that we had these two lectures prior to my lecture because I know that you are now primed and ready to hold the stick from the other end. So far, we have learned that these are the features of A, B, C, all the lesions of carcinoma up to carcinoma cervix. And unfortunately, tumors and lesions do not read book. So they come with all intermediate grades. They come in a way masquerading as various other pathologies. And it's our job to give that nameplate to them. Okay, so let us start. Next. Okay, here can is the pointer there? Is it working? It's going ahead. This is going ahead. Pointer, I just wanted to confirm. I'll use the mouse then. Okay. So, needless to say, it's all about saving a life which is precious that we are doing this exercise and diagnosing carcinoma cervix at the earliest stage would definitely save this precious life of half the population in India. Okay, so it's a mammoth task, of course, and there are these technologies coming to our aid, that liquid-based cytology, which I'm glad that you have adopted this time. I have thin prep, not sure path, and they both have their advantages and disadvantages. Okay, so LBC definitely has an edge over conventional when it comes to picking up epithelial abnormalities. Although it's not our aim to diagnose inflammatory conditions of cervix, it's a very helpful byproduct of pap smear that the gynecologist would agree, and it does save accurate diagnosis of this, does save female a lot of morbidity also and pain and discomfort. So in all these respects, LBC has an edge over the conventional cytology. So just a quick check of ABC. A lot of this has already been said. So essentially in thin prep smear, which is spread over wider area, you are looking for at least 3 cells per hyperfield, and in sure path you are looking for more than 7 cells per hyperfield. Since the cells which are collected are directly immersed in a liquid fixative, they would look smaller, get rounder, and both the methodologies, that is the filtration and centrifugation is there in some way in both the technologies, that will break the cells and disperse them so that they would look separated. But it also makes the cells adhering together more compact. So you would be getting a unique problem in liquid-based cytology, which even in conventional it can be there, but more appreciated in liquid-based cytology because of dispersion of other cells, that is the hyperchromatic crowded groups. So you'll be immediately visualizing these hyperchromatic crowded groups, which are a seat of many epithelial abnormalities. Okay. Just quoting a few, how liquid-based cytology differs from conventional cytology. Remember that the pathology remains the same and you can easily apply your knowledge of conventional pap smear to liquid-based cytology. In atrophy, the background of inflammation, necrosis is gone. Pycnotic cells are also many times washed out, and you may see such flat sheets of parabasal cells. TV, which is a notorious and difficult to identify unwanted visitor in pap smear in conventional cytology, is better visualized in LBC. The flagella and the granules are better seen definitely. There are some entities in which in conventional smear you don't even have a problem, like follicular cervicitis, where you get a lot of lymphocytes, but a cluster of same lymphocytes in LBC would pose a problem in liquid-based cytology vis-a-vis conventional smear, and you need to identify new lymphocytic nature and the tingible body macrophages there. Metaplastic cells also many times get separated. Okay, everything that I'll be talking about then comes down to the nuclei in the smears. Okay, so we often talk about these changes. Let us have a good illustration of these changes. Okay, so for diagnosis of each and every disease, we'll be looking for these nuclear changes. So here now the blue arrow, can I just use the mouse? Okay, so look at the nuclear angulations. Even in degenerative nuclei, you will see some angulation, but they are predictable. One part goes up, other part goes down, that kind of a thing. Okay, whereas in epithelial abnormalities caused by HPV, you will have unwanted, unpredictable angulations. Okay, then you can have these bites like this. This green arrow is showing the bites in the nucleus. Okay, and we often talk about variation in nuclear membrane thickness. Can you see thinning and thickening? Okay, so these are the things you look for in the nuclear membrane. Next, we often talk about chromatin. Ultimately, it rests on these things, so these are very important. So you have irregular and altered chromatin pattern and distribution. Okay, so if you make 4 parts of the nucleus, the basic caveat of identification of a malignant or abnormal cell, if you make 4 parts of the nucleus, the type of chromatin in all 4 should be similar, barring the presence of nucleolus or few chromocenters. Okay, then varied granular pattern would be seen in epithelial abnormalities, starting from fine to coarse, and at times you can have these chromatin granules of the size of lobe of a neutrophil. Then those neutrophils are often available. You can always compare and get an impression about the size of these. Irregular chromatin granules, pointed projections and indentation also can be seen, and hyperchromasia and variation of the chromasia. Some would be very hyperchromatic, some may look a little less chromatic. So variation of hyperchromasia is also seen when you see these abnormal cells. 2 more things. We talked about invasive malignancy. Invasive malignancy, though easy to spot, has certain other features besides tumor diathesis and nucleoli. That is the parachromatin and paranucleolar clearing that is often seen in invasive malignancies. Okay, so these 2 features also you should add to the list of invasive malignancies. Nucleoli. Nucleoli are easy to find when they are multiple. When 2 nuclei in one cell vary in size, this is definitely a feature of atypia. There could be angulations to nucleoli. We just talked about the paranucleolar clearing also, and larger nucleoli, more than 4 times the size of a normal nucleolus, are often seen in malignancy. Okay, 3 to 4 is taken as borderline, and they do look eosinophilic. Why? Anyone who can tell me why nucleoli look eosinophilic and nuclei look blue? Simple answer to a very common question. Nucleoli are made up of RNA. Okay, so that's the reason. Some differential staining is always there. So we come to the case part. Okay, 30 years, a young patient coming with discharge PV, LBC smear is prepared, and it is a satisfactory smear. Okay, what do we have? At first glance, the cells look well dispersed, they are squamous. Okay, and then an occasional cell starts popping up like this. Okay, so this cell, what does it have? It has some condensation of chromatin. How is the nucleus? We always focus on nucleus, isn't it? So is this abnormal? Is this resinoid? Not really. Not sure. Let us go further. Okay, so definitely condensation is there. This is not a hyperchromatic nucleus. In fact, this is somewhat hypochromatic, isn't it? Here you can see some vacuoles which are close to nucleus. Very small vacuoles, isn't it? More vacuoles are seen. Remember that in LBC your background is taken off. But here you can still see some dirty material here and there. Okay. Now this one has definitely an enlarged nucleus. Enlargement is definitely there. Okay. Some are really showing a little indentation. Okay. So definitely some coilocyte-like abnormality. Okay. And then we saw one group like this. Okay. Hyperchromatic, showing nuclear angulations. Can you see the angulations here? What the things we need to note here is that if you compare size of an intermediate cell nucleus, 3 nuclei would be accommodated in this, isn't it? Okay. Is there any inflammation? Not much. Here is some small aggregate of inflammatory cells. Nucleomegaly is definitely there. Nuclear membrane we often talk about, and whenever you have such a group and you want to look at it, put a drop of oil and examine with oil. That gives you best estimate of nuclear membrane and the chromatin pattern. Just looking under high power would help you identify these cells. Okay, so always a good practice to put a drop of oil there. And our report depends on how many such cells we find. An occasional cell, we are in a phase. Should I call this ascus? Should I go to LCL? Okay, so let us see. Suppose this is an AIIMS. Okay, in LBC inflammation is gone, but you will still see some adherence of cell to each other, and some of the neutrophils also you will find singly adhering to the cells. Reactive cellular changes of inflammation would be same as you see in conventional pap smear. Okay, and perinuclear halo is one of the features of that. So just a quick recap of cellular changes of inflammation. What do you have is polychromasia, that is the variation in the color of the cytoplasm. You can have cytoplasmic vacuolation, nucleomegaly, karyolexis, karyolysis, pycnosis. Okay, all words, or you have a clear idea of what do they look like. This is karyolysis, pycnosis and karyolexis. Nuclear membrane is maintained in karyolysis. Pycnosis, you can't see anything inside the nucleus. It becomes really small. And karyolexis, when the nuclear membrane gets disrupted and the chromatin comes outside in the cytoplasm. Okay. The vacuoles, when seen, are not always coilocytes. And there is something called pseudocoilocytes, which you see in many inflammatory conditions, like TB, trichomona vaginitis, candida. These are smaller vacuoles. If you see carefully, the condensation is more surrounding this space and not at the periphery. The peripheral condensation is not that much. Look at the nuclei. These look quite okay, isn't it? Quite regular nuclei, not much variation. This one is a little smudged and larger. Okay, so these are pseudocoilocytes. When you see such things, you have to search for TB and candida primarily, but some other agents also you can see. Okay, do not mistake this normal glycogen vacuole ever for a coilocytic change. So these are the coilocytes in comparison. Okay, immediately you can see sharp angulations of nuclear membrane. Some wrinkling there, a binucleation here, cookie cutter age is there. Okay, this one is not showing much of a vacuole, but the nucleomegaly as compared to intermediate cell is quite clear. So what do we do with this now? We need to separate definitely AIIMS and this thing, LCL. And these are the features. More nucleomegaly in dysplasia. The cytoplasmic features are quite distinct. Chromatin is dark and irregular in dysplasia. So a careful look at the nucleus is essential. And this TV, which is seen with cytolytic background and leptothrix. Cannibalism, which is very quickly picked up in LBC. Okay, necessitate a search for these trichomonads which stick to the epithelial cells, or for candida, which in LBC is seen as a hyphae to which these cells are adherent, and this is called sheikh kebab, isn't it? Okay, shish kebab. Shish kebab or shish kebab, I'm not a foodie really. Okay, so this is what you see. If you do not see hyphae and you see just the candida forms surrounded by a halo, then you also have to consider diagnosis of Candida glabrata, which is a common species. Okay. Just to complete the list, HSV would show vacuolation, but these are surrounding, they are inside the nucleus, okay, multinucleated. So coming back to L-cell morphology, what all things do you see? You see binucleation, coarse chromatin, nucleus 3 times the size of intermediate cell. So you compare the sizes of nucleus, and the cell also is a large cell, but the nucleus is also quite big. Okay, so this is L-cell morphology, and as Rahul told, coilocytic change is not to be equated with L-cell. If coilocytes are present, this can be L-cell. If coilocytes are not seen, still it can be L-cell. It is not mandatory for the diagnosis of L-cell. And if you correlate with cytohistopath, then this upper parakeratosis you would see in smears of all L-cell as small keratinized cells. Okay, the importance, or if these are abundant, it means that you have to take a deeper scrape. You have to sample an area after removing that leukoplechic or keratinized patch, sample a lower area. That is a must whenever you see parakeratosis or hyperkeratosis. Coilocytic change is of course there, and then you can see certain changes in the endocervical cell also, but which are not diagnostic. Okay, so always beware of these incomplete changes associated with L-cell, and halo is not mandatory for L-cell. Okay, when coilocytes are seen, it becomes very easy. We had in that group, which I showed later, not many halos. Halos were seen in other cells individually, but not showing classical nuclear features of coilocytes. So we did one HPV testing. Okay, what are the high risk groups? 16 and 18. Okay, does this include the entire list? There are others also, we should be aware of that. But if 16 or 18 is positive, this is a good way to triage patients who need to be taken for colposcopy. Okay, so that is my main message in this talk, that this was a huge trial which was conducted, and in which anything like if ascus or LCL is reported, which one needs to be further treated, and which should we just follow up this after a certain time? Should we immediately do colposcopy or what? So for this trial was done, it had 3 limbs, and this confirmed that if you have such a morphology, you need to do high risk HPV testing, confirm that it is high risk, and these patients on priority need to go for colposcopy. So this was confirmed as a way to triage the patients. Okay. Reflex testing is done on whatever, this is one of the main benefits of LBC besides finding the epithelial abnormality. If you find some abnormality there that you are suspecting is caused by HPV, there is no need to again call the patient and collect a sample. In the same, you can do HPV testing. Okay, and this definitely has a role in the management of cell patients. Okay, some of the newer tests like Aptima have been approved, and more complex and more costly also. Okay, so what is the take-home message when LCL is present? With or without inflammation, with or without coilocytes, a careful evaluation of smears is needed. to confirm what is the nuclear abnormality, and in any problematic case, HPV testing would help you to solve the dilemma. Okay, so that is my first case. A small spotter there. This was already shown. What do you look for? What do I look for if I find such cells? What are these cells? Can you describe? Some large cells with accumulated cytoplasm, bubblegum. Okay, what are they? What do I look for? I look for these. What are these? These are woolly materials which look acellular, somewhat thready. At the periphery, there could be attached leukocytes or some clumps. What are these? Yeah. Okay, so Gupta bodies. Okay. Dr. Gupta was a very acclaimed teacher at PGIMER, Chandigarh, and she was the one who first described this in IOD. Okay, we have found numerous cases. Whenever we have this, we just confirm the history of IOD, inform clinician, and they take care of the rest. This was a real revelation for us. Okay, a young female came with very fungating large expansile growth. Okay, and we saw this. We did FNC. Now, what is FNC of cervix? Whenever you have large growths of cervix, even if you take biopsies, only necrotic material sometimes is there, and biopsy is also inconclusive. So, a very simple way we devised and published in ACTA also, that what you can do is that attach needle to the tip of syringe and just push it at various places. What happens is that wherever there is tissue resistance, the cells would enter the needle. So it will pass through necrotic tissue and only the viable cells would enter your needle hub. And you can just push on a slide, take out the syringe and again push on the slide, spread it, you get beautiful viable cells. Try it sometimes. Okay, and the same material can be used for any cell block, anything. Okay, so here we did FNC. And biopsy was also, of course, biopsy was also done. The patient was there, he had a mass, so biopsy was also done. Before biopsy came, we saw this FNC smear and called gynecologist. Dr. Gadkari was there. So she said that the patient will come in 2-3 days. I will just confirm she's known to me and I can call her. Okay. So when the patient came, the whole tumor had disappeared. So what are these? Yeah, this sir is right. So, you can find entamoeba histolytica in our patients. The RBCs in the cytoplasm are a great clue for that. Okay, and they would resemble histiocytes, but you can have entamoeba there. Okay, so let us go on to next common problem. I have selected cases so as to highlight common problems that we encounter and how to deal with that. Okay, so postmenopausal female, pap smear, she had white discharge and there was an erosion present. Okay, so this is the first slide. You can see some keratinized cells here which immediately alert you. There is some nucleomegaly. Okay, and then these are hyperchromatic crowded groups. What are these? These are some inflammatory cells sticking to the cells, isn't it? But no obvious agent is seen in this smear, right? Is this a little bit of spindling? Would you worry about this smear or not? Yes, because I am presenting? No, because I am presenting. Both options are open. Okay, so let us go on a little further. You can definitely see these cells with megaly. Okay, even in single cells you can see somewhat megaly. But I told you, what do we look for? We look for nuclear chromatin abnormality and nuclear membrane. Is it there at first glance? No, it is not there. So this is a very common problem. Let me tell you, almost 70-75% of cases that we often review reported as either ascus or HSIL often are smears of atrophy. So how do we identify these atrophic smears? Okay, lot of changes. You will have syncytial sheets in LBC. Okay, whenever sheets are made of squamous cells, always remember they tend to flatten out at the periphery. Okay, there could be some keratinization, which is pseudo keratinization. Often patients come with prolapse also, that also causes some keratinization of various degrees of cervical descent is there. Pycnosis is always seen. Always look at nuclei, nuclear membrane. If those irregularities are absent in a postmenopausal female, you have to be guarded. Okay, don't overdiagnose these things. So you will see hyperchromatic crowded groups of 10 to 15 cells or more in LBC. Remember that most are not neoplastic. Almost 80% won't be neoplastic, but this also means that 20% are, and they are spotted very easily. So look very carefully. They could be of parabasal. Okay, very common in atrophic smears. Here, what do you see? What do you see? Palisading, isn't it? So this is a simple endocervical HCD. Alright. Then reactive endocervical. Dr. Rahul told you about the reactive changes in squamous also with streaming, school of fish. Even in endocervical, they start becoming hypochromatic and they cluster together with inflammation. Okay. An important thing to see is where are the nuclei placed? Is there nuclear knobbing in these clusters? If the knobbing is present, we call it feathering, isn't it? Are there some distinct glandular arrangements here? Is there mucin there? All these features are important. Once you have ruled out these, you can call this reactive endocervical. Okay, and then of course endometrial clusters, which over a period you learn to identify. So all these are hyperchromatic crowded groups which are not malignant. And there, so ascus would look like a school of fish. One important feature which I always emphasize to my students is that in any atypia of repair, you would have nuclei which are hypochromatic. They suddenly would look paler than, they are definitely larger, they show nucleolus, but they are paler nuclei always. So pale nuclei always give more thought before calling it epithelial abnormality. And if you remember your breast pathology, what do you see? Say in hyperplasia, there is streaming. So keep looking for streaming in these repair cells. Okay, any reactive change from body would have this streaming. Same is true about cervix also, and then you will have streaming of cytoplasm. Okay, so nuclei are the key. Keratinization also may be seen in atrophy. This was just an atrophic smear, and you need to diagnose it as such and not raise false alarms. Okay, one term I want to just touch before we go any further. That is the term dyskaryosis and dyskeratosis. Dyskaryosis, we are talking about the nuclei. Dyskeratosis is the type of keratinization. So premature, seen earlier than what it should be, not less than superficial cells. Hypermature, more of that. Any of these with an abnormal nucleus would be a typical keratinization, and we call that dyskeratosis. Okay, and then whenever you see such a nucleate or keratinized squamous cell, are easily spotted. But remember, there are multiple causes, and you have to look very carefully at various things. For example, how much is the keratinization? Are they overloaded? It starts becoming refractile and the nucleus drowns inside the cell. So that is a SCC type of or keratinizing dysplasia type of keratinization, or otherwise you can keep seeing these anucleate squamous cells variably nuclear changes are equally important. Just because you are seeing keratinization does not become a squamous cell carcinoma. This type of keratinization would be seen in a keratinizing type of high cell. Okay, so high cell is also various type. One of them is keratinizing type of high cell, and there you would see these dark hyperchromatic, almost ranging to black nuclei. Whenever there is such type of keratinization is there, and then you will see hyperchromatic nuclei. Okay, just highlighting few changes. Squamous metaplastic, you must identify some tapering of cytoplasm, a larger nucleus, much more hypochromatic unless it is dysplastic. These are some of the very common of misdiagnosing or false positive epithelial abnormalities. Okay, I'll just go ahead. So how do we solve the problem? I'm not very sure. I think that I'm experienced enough to call this atrophy. But still, I would like to be sure before I give this away finally. Because our patients, if once we told them there is nothing to worry, they never come back. Okay, so let us be sure before I send them off completely. So you can give a hormonal cream, and then you can see that, and of course treat any inflammation if present, and then a repeat smear would ensure that this is just atrophy and nothing is wrong. Okay. So what is the take home? In a postmenopausal female with predominant parabasal cell. Okay, sometimes you feel that with inflammation there are halos around the parabasal cells. Is this coilocytic? Is this H cell if the nucleus is large? Remember that in atrophy you are going 360 degrees and most of the cells would be parabasal vessel, depending on the degree of atrophy, of course. In some patients it is late, but once atrophy sets in, most of these cells would be basal parabasal. Whereas any epithelial abnormality seen focally that we want to detect would be a subpopulation of all the cells collected. So this is also an important clue. Okay. Third case. Okay. So this I have chosen to highlight how we keep saying that epithelial changes are seen better on LBC. How is it that? Okay. So on right side is the conventional smear. Dark sheets, some sheets are seen. Lot of single cells are also seen. In LBC, those groups are somewhat showing the nature. Okay. Again in conventional smears, what are these cells? They definitely have nucleomegaly. Yes. Do you have nucleoli in one of the cells? Yes, I feel there is some nucleolus. Can you see the background? Blood is there, but with blood there is something else. What is it? Necrosis, tumor, little bit of tumor diathesis. Okay. So a lot of these sheets are seen, large sheets with some tapering. We have this problem. Is this glandular abnormality or squamous? Remember that both coexist, both mimic each other, and as Madam rightly showed, lot of glandular changes that you report on are actually in final diagnosis itself. Okay, so there is great mimicry between these two, and not forgetting lesions like adenosquamous carcinoma when both can be present. There can still be problems of overlap between the two, and in endocervical carcinoma again HPV is positive, isn't it? High risk. So all these things need to be taken into consideration. Okay. So when you see these groups, differences between glandular and squamous groups. Can you see this spreading out at periphery? Okay. Here also these nuclei are looking more or less columnar. Can you see the chromasia here? They are much more darker. And if you start looking at these cells very carefully, you will appreciate that squamous cells have somewhat 3D appearance. Always remember. They have, if you put under high power, the nuclear changes, they have somewhat 3D appearance, whereas columnar cells often look flat. Chromatin clumping and irregularities, unless it is a carcinoma, are not pronounced. Okay. So these two, along with other cells, need to be differentiated. Atrophic we have seen, parabasal, metaplastic and H cells. So this is a comparative diagram thanks to Dr. Siddham, who has co-authored in one of the books that we recently published on carcinoma cervix. He has written 2 beautiful chapters on H cell. Please go through that book, or in cytojournal article that madam has referenced. He has given these differences beautifully. So do take reference of that. Okay. H cell. Is this H cell? H cell can look at this checkerboard pattern, as we call it, or they can appear as syncytial sheets like this, or singly. But going back to our case, we need to see what are the accompanying cells. Okay, and then when you have such a cluster, always focus at various places to find whether there is any glandular pattern, feathering or mucin. Okay, we'll just skip these because tubal metaplasia and other things also can appear as glandules. Okay, so look at this carefully now. Hyperchromasia is much more. This is a checkerboard pattern. This is somewhat syncytial pattern. Vis-a-vis elongated cells, some even chromatin of glandular atypia. Okay, in LBC now what did we have? Under high power we could see these clusters. There is something like a nucleolus here. Okay, here. Keratinized cells. Now what is this? Almost, but not really tadpole. So I'll search for more. And in all these necrosis are hidden cells, which if you focus appeared like this: spindle cells, fiber cells, and then a more careful look at LBC showed us all these classical appearances of a squamous cell carcinoma. So this was squamous cell carcinoma. I just want to highlight that squamous and adeno do have an overlap. They need careful evaluation. The gynecologist would be happy exploring it further once we report that. So that is not a major issue for us. It may be for them, but not for us. So, these are some of the problems we encounter on histopathology. In this case, we got a biopsy also, colposcopic biopsy, and it turned out to be a squamous cell carcinoma. So, for problem solving, for invasive carcinoma, you have to look at tumor diathesis, the various nuclear and nucleolar changes that we talked about. Close attention to keratinized cells. Any keratinized cells, look whether this is hyper, showing dyskeratosis, whether tadpole cells and other cells are present, whether the nucleus is drowning in keratin. Colposcopy biopsy in a problem case, P16 and Chi67 showing high proliferative index, P16 positivity which is block positive. This all will help you diagnose squamous cell carcinoma. So take home is that they can mimic, they can coexist. They need to be separated. Why is it important to any one of the pathologists? Of course, madam of course knows, but any of the pathologists knows why it is very essential to differentiate adenocarcinoma and squamous cell carcinoma of cervix. How is treatment different? Radiotherapy and okay, so if you diagnose one over the other, it persists, does not go away. So many of the tumors, sometimes they are adenosquamous. The squamous disappears or adeno disappears, and the other one is seen in the recurrence or in the metastasis. That also happens. So the two need to be differentiated for us. Now this is my favorite, a very interesting case, Madam will agree with me. So this 50 years female had a bleeding PV. We did a pap smear. On ultrasound, they said nothing was abnormal. Endometrial thickness millimeter. There was no mass in ovaries, no other enlargement, nothing. Why did they look so carefully at everything? Because we gave them this report. We saw this in PAP. Okay, so no doubt of malignancy here. I am not going to talk about malignant cells here. Anyone has doubt of malignancy? No. There are clusters of malignant cells with hyperchromasia. Some vague glandular arrangement can be seen. Okay, but essentially there are clusters of malignant cells with difference in type of chromatin, hyperchromasia. Some elongation of nuclei is also seen there. So squamous over adeno? No, adeno. More likely adeno. Alright, this is even better cluster of papillary cluster of cells showing malignancy. So we said that maybe this is arising somewhere higher up, endometrium or otherwise. So they re-evaluated their USG and other things. They said, madam, there is nothing there. Why you are saying so? So they don't believe us usually, no? You are lucky that your gynecologist has a good rapport. We also had, but there would always be some people who won't believe your report. They did a endometrial wash. Okay, again we saw the same malignant cells in the endometrial wash. High power of these, again showing these tightly aggregated irregular clusters of cells with nuclei, focal nucleoli, nice glandular arrangement now visible. Okay, so we were insisting this is adenocarcinoma, madam, nothing else. Okay, so just recapitulating those features of columnar versus squamous, hyperchromasia, interclusters. So adenocarcinoma. Okay, so in pap smear we have adenocarcinoma. Some normal endocervical cells were also seen in the smear. Okay, they did an endometrial biopsy, so normal endometrium was seen here. Along with that were these malignant cells. Okay, again ovaries were seen. What to do? Hysterectomy with bilateral salpingo-oophorectomy was now done. Okay, so gross specimen. Okay, we were waiting for this because lot was already said about this case. So we were waiting for that, and you know how a bit is missed when you receive a normal looking specimen when you have given malignancy. So nothing again there. The entire thing was sectioned to look for malignancy. Ovaries are also not looking enlarged. We then did something which we all would do this. So we did a CFIM. Okay, so serial sectioning and extensive examination of filtrated cell. Now since last, I think 2016 it first came, we have been talking about origin of high-grade serous carcinoma in fallopian tube, isn't it? So since then this CFIM protocol is being done. So let us see, this is the normal fallopian tube, okay? And in normal fallopian tube, just a quick recap, has secretory cells and ciliated cells. Now these secretory cells are the site for all these lesions, and they would start proliferating. There would be multilayering, loss of polarity, and accordingly they would be called SCOUT, that is ciliary outgrowths, secretory outgrowths, secretory tubal intraepithelial lesion, and a later stage of that would be STIC, serous tubal intraepithelial carcinoma. Okay, now there is nothing intraepithelial about what we have been receiving. So a complete sectioning of that and the lymph nodes showed us that all these microscopic features of epithelial stratification, lack of ciliated cell, high NC ratio. Along with that, of course, there was invasion also seen. We had no need to do a molecular signature in this. It was quite obvious. So it was seen in both fallopian tubes. Now when you have a stick, it spreads along the surface often, and invasion comes later. Now this spread along both the surfaces. We got this in endometrial biopsy also. So in all probability, it extended over the isthmus, being present in all this, and that was the area which was scraped during biopsy. That was the reason we did not see any carcinoma there. Maybe it was a small area, but we did find some psammomatous calcifications in the endometrial wall. And then carcinoma was there. There was a small focus at the right corneal end also, and the lymph nodes had metastasis. Okay, so this is how it would look early on. That is the proliferation of these cells, which suddenly start looking very blue as compared to this area. Multilayering is there, loss of cilia is there, okay, and then NC ratio and other features of malignancy would be there. Invasion comes late. And remember, what is the basic property of fallopian tube? Physiological property of fallopian tube. What does fallopian tube gets every month? An egg, isn't it? What does it do? It just takes it towards the uterus. So this is what these exfoliated cells were taken to uterine cavity, and from there it dropped down in the pap smear. Okay. So our final diagnosis was high-grade papillary serous carcinoma of bilateral fallopian tubes with stick in one of the tubes, and then lymphovascular invasion was seen, lymph nodes were also there, and so pathological staging was done as T2 and nodes were positive. All right. Similar reports we checked on net, and there are few random reports of similar happenings reported. Okay. In this, unusual thing was that usually by the time this is detected, patients have ovarian carcinoma. This remained in the fallopian tube. That was the unusual thing. Alright, so what is the take-home message? In presence of malignant cells, you should stand firm that yes, I am seeing malignant cells, and definitive procedures are definitely needed in these cases. Okay, just one small common ailment that I would study. 49 years, again elderly female. This, now you tell me, what is this? How are the cells, large or small? Are they squamous or glandular? Okay, what do you think this cell is? Or this? This is a tingible body macrophage, and this is one of the common pitfalls of LBC you must be aware of. This is a very benign condition. When you see such cells, what are your differentials? Are they small cells? Small cell carcinoma to nahi hai. Non-keratinizing squamous cell carcinoma, small, sometimes cells are small. Is this like that? Is that tumor diathesis? So you check for tumor diathesis, you check for any evidence of nuclear disorder. Look at the nuclei carefully. Most of the cells would have uniform type of chromatin and nuclei, and then search of few cells which are invariably there near this cluster, which would resemble, have a small rim of cytoplasm of lymphocytes. Many a times at least one tingible body macrophage containing debris would be seen inside, and that is your clue that all is well. Okay, this is just follicular or lymphocytic cervicitis which you see in elderly. Okay, so these are the differentials of small cells. Rarely you can have a small round blue cell. Can you quote any one example when you see small round blue cells in cervix? From where do they come? Say a 14-year female. I have seen 2-3 cases of that. Which malignancy would be there? Small round blue cells. It's the botryoid, RMS, rhabdomyosarcoma. That can sometimes come. Urinary bladder is a common site, but we have seen cases in cervix also. Okay, but those would be very hyperchromatic malignant cells. Sometimes, but with cytoplasmic tails, myxoid material, clinically the patient would be bad, definitely. It won't be an asymptomatic patient. He would be having a big mass somewhere. All right. So non-keratinizing squamous cell carcinoma, we have given one or two small cell which turned out to be non-keratinizing squamous cell carcinoma, and few non-keratinizing squamous cell turned out to be small. So they say that this specificity is less, ability to identify may be less. IHC is a great way to differentiate between the two when you have these. Okay, so small cell will look something like this. Typical saltpeter chromatin is difficult to appreciate in pap smears, but you would see very similar looking cells with high NC ratio, nucleoli would be absent, apoptosis would be present, and tumor diathesis would be. So malignancy would definitely be evident. Alright, and follicular cervicitis is a very benign looking animal in your conventional pap smear. So all the cells are nicely dispersed. You can identify the histiocytes also and lymphocytes also. Alright, so what is the take home? You must know what are the mimics of any given condition. Knowledge of mimics is a must, so that false positives or false negative can be kept at a minimum. Okay, so that is one of the cornerstones of our diagnosis everywhere. False positive, a definite no, isn't it? That is the worst error we can make. So we must. Despite this, you will find some discordant results in histology and cytology, and clinicians will ask you to explain why they are looking at this. So maybe that lesion is very small, maybe it is very high up into cervical lesion, or very low. Maybe the lesion is somewhere in the vagina or vulva, and you are scraping the cervix and the area is not sampled, and later on it is detected. Okay, there could be sampling issues also, or sometimes the lesion is so atypical or so unusual, like I showed amoebic. Okay, we don't think of these things. Very rare, the dictum is that very rare diagnosis should be done rarely, isn't it? So sometimes we don't think of these very rare things and they are missed. I see in problem solving is a great help. In HCl, P60, in fact, these are the two markers which have been validated, approved, and found to have a role in diagnosis in cervical cytology, that is P16 and Chi67. So P16 would be block positive, very nicely positive, strongly positive in HCl, whereas it is very weak and diffuse or non-existent in LCL. You can just leave these cases. If you have a biopsy and a problem, then you can do these things, because sometimes there could be very thin layers of HCLs. There are multiple problems in histopathology where you may need help of these to give you a final diagnosis. And also, of course, proliferation index is also high in HCL. Okay, risk of malignancy, now this is a little untested area here, but in all others HCL has the highest risk of malignancy, and that's why HCL and above always we are want to find out. Rest have a variable risk. Again, ask H has a very high risk of malignancy. These are some of the newer tests which are coming up. There was a big article on DNA methylation markers being identified, hypo or hypermethylation, which are epigenetic changes in carcinoma cervix. Some microRNA detections are also being evaluated, but all this is still on the bench, not at the bedside. These investigations, you should just know the names of that they are being evaluated, and the tumor markers CA125 19.9, which are being done for other carcinomas. In absence of those carcinoma, raised levels may be seen also in cervical carcinoma, especially in adenocarcinomas. The one thing which always is a very painful thing is the magnitude of this disease in India. And what we can do, how many are we screening? We are mostly doing opportunistic screening. In small places, we go and do community screening, doing camps for which the turnout is something like 10%, 20% many times. So a large population remains totally untested. We need so many times cytotechnicians, cytotechnologies, awareness and will of the female to make her life better. Remember that for her, who may not be having a second meal next time, telling her that 10 years on you may have cervical carcinoma, getting her ready for screening, doing screening, asking her for follow-up, all these are very difficult issues which fortunately we don't have to face but are the real issues. Okay, so our endeavor should be to diagnose it correctly, to diagnose it quickly as far as possible in 1 or 2 visits. So help clinicians reduce the number of visits. This is a very important thing. Okay, so that is it. That first step has to be taken. Howsoever difficult the journey may be, a long way to go still. I from AIIMS Nagpur, this is the OPD of AIIMS Nagpur. I'm very grateful to sir for calling me, Rahul, other faculty members for the affectionate hospitality, and I thank madam for attending the lecture all through. Okay? So thank you.